Okay, we're going to talk about our placement of the StimRouter on the proximal tibial nerve, proximal to the tarsal tunnel. We place it usually at the junction of the distal soleus and gastroc. The indications for this would be any type of failed plantar surgery, such as multiple Morton's neurectomies, catastrophic forefoot reconstructions, anything where there's a lot of pain plantarly. And we will oftentimes augment placement of the StimRouter proximally in addition to doing whatever we need to do distally. We find that a very valuable augmentation or addition to the procedure. So we can see on ultrasound this nerve, and we can see the nerve right there. And if we had this in an in vivo situation, we would be able to turn on the power Doppler and see the artery, which would help us confirm our location as well. So we can clearly see the nerve right there. So that's a great spot. We can mark that with ultrasound location, or we can use topographical locations. So now that we've illustrated where we would start to hunt for the tibial nerve with ultrasound, we can also look at this from the standpoint of what would we do if we did not have an ultrasound and we were just doing, our standard anatomy. So first thing, the easiest thing to do is palpate just anterior to the medial calcaneal tubercle, and we know that the lateral plantar nerve is going to go in that area there. So underneath the abductor hallucis, the lateral plantar nerve course is just anterior to the medial calcaneal tubercle. The medial plantar nerve is going to be in this area here, again, coursing underneath the abductor. And we can palpate the malleolus in this area. And so we know that the posterior tibial or tibial nerve is coursing in this direction here. Now, we can feel the tibia very well here, and we can feel gastrocnemius here. So we know that that nerve's going to be exiting right between those two muscle bellies. So if I did not have an ultrasound, I would probably just go from a palpation standpoint, and I could feel with my thumb that area right between medial gastroc, which I have here, and the soleus, which is near the tibia. So we're going to come in this area here, and I'll make this incision just a little bit bigger than I normally would so that we can see the anatomy. So again, blunt dissection technique, we can take this right down to the fascial level. And again, with our finger, we're able to get right down to the fascia almost immediately. So we can see very clearly, here's the deep fascia, and we can just then gently lift this fascia up. And many times, when we've already done a tarsal tunnel in the traditional area, we can just come up here and you'll find it very tight. So we want to do a fasciotomy, so we get the benefit of the fasciotomy as well. And that can be pretty beneficial, and I think make the StimRouter even that much more effective. So we just need to, now that we're through the fascia, we just need to find the neurovascular bundle. And we've got some nice tendon. And it can sometimes be fairly deep. Let's go distal just a little bit. Here we go. Perfect. We got the neurovascular bundle right there. Let's see if we can redirect that. There we go. So we can see the vein. Usually when we see the vein, we like that because we know we're in the area of the nerve itself. And sometimes this nerve can be pretty posterior. There's the tibial nerve hiding in that synovial lipomatous type. So here's our tibial nerve here. There we go. There's a lot of fat around this nerve, but here's our nerve. At the tip of my scissors, you can see it very clearly. This is where we're going to place our StimRouter, and we're going to show two techniques as far as exiting and ultimate placement. So if I have my obturator, the first placement that we're going to do is where we don't have to coil everything here. Sometimes it has been referred to as the candy cane approach. And we're going to run this subcutaneously, and we're going to try to get it out maximally here. Slide our cannula back, and then that will allow us to run this lead all the way up, and then we'll bring it back down to use our full 15 centimeters. And that would make this point about 6 centimeters from the receiver to the electrode, which is pretty ideal. We talked about it being between 5 and 10 centimeters. So let's do that. Again, I'm not squeezing the electrode, I'm just gently running it through. And that will allow nice placement for us. Once we take this out, we can see that that lead, or that actually the electrode, will be adjacent to the tibial nerve. When we place our leads with a cut-down procedure, we like to remove these little barbs so that we just have less material that could, irritate the nerve if there would be some migration. So I've already done that on this stimulator. So you can see the barbs have been removed. So that's what we standardly do. All right, so we have our tibial nerve, and we have our Bioness stimulator in good position here, adjacent to it. And we are going to find a little piece of fascia, and I'm proximal to where the barbs are. So there's my fascia. And I'll just tie it to that. And now I've anchored it into a good position. It's not going to migrate. And normally I will use a monocryl, but for video purposes we used a nylon so that you could see it. So now that's going to hold it in good position. So as I removed the cannula, you can see the remaining lead wire here. Now I need to bring this down to a place in this area so that when the patient is ready to have the stimulator actually started, we have, the distance between the electrode and the transducer and the receiver about 6 centimeters. So we're going to rechannel back from this spot here and bring it out this way, and then our lead will be subcutaneous. Our goal is to bring this into about this position right here, and we don't want it over the bone, so we want it in this area right there. So probably the easiest way to do this is without harming our lead wire. So now we have kind of found our location, we come through again, and as we did before, we can feed this right over and bring it out. Retrograde this, and then feed this back in here. Now, we don't necessarily know exactly where that transducer is that way. Okay, so now we're going to do a traditional loop placement. So we want the end of our electrode is here, and we want about 5 centimeters, so we can come out in this area right in here, which is a very reliable way to do that. And we can so now we're back in, withdraw the trocar, and we can now run the lead back here. Now, we should have plenty of lead, so as I withdraw, we can see that we have plenty here. So we need to just do a loop to bring this subcutaneously in this area right here. So we have, I think with this technique, a pretty good idea of where we are subcutaneously, and we can just lay this down. And as our deep tissues, we'll cover this up. So there we go. A little springiness in it. We relax our, and we can see now we've got pretty good placement. So electrode here, receiver right here. Now that we know that our electrode is here, our receiver is here, this is going to be a very comfortable place for the patient to wear their patch. And as we can see, once this incision is healed, in approximately 21 days, they'll be able to wear this comfortably in that spot right there. One of the major considerations that you need to take into account when you're putting in a StimRouter is where is that patch going to be on that patient's extremity. Because when they sleep, most people will abduct. They will be in this position here. So medially, anywhere medially is a pretty good place. Laterally, we have some problems. A lot of times they won't necessarily be able to tolerate that when they sleep because they abduct their legs so much. So ideally, and for the tibial it's very easy, if I was going to do a surl, I would make sure that I would bring my patch as far medial rather than posterior as I could.